we'll just go around the room. Tell me where you work too, please.
Okay, I'm Anita Palmer, and I'm an OR scheduler.
Ah,
Amanda Mungan, I'm Brett Keene's assistant, cardiovascular emergency services.
I'm Georgia Barton. I work for the lab in the nursing home program.
ah.
I'm Diane Reed. I'm a monitor tech for the hospital.
I am Vicky Petrie Dillon, and I am working for the school system.
Oh, yeah, school nurse.
I am a school nurse and also supervisor.
Good.
I'm Elaine Cochran. I used to work for Women's Health Center, but now I'm one of the centralized charge posters.
Oh, yeah.
So just getting that underway.
I'm Greg Winger, I work in information services.
Ah, one of the guys from the basement.
Yeah.
Good. Well, I have always done these gatherings, and when I got to Meritus, I got really busy really quickly, and I didn't initiate them right away, so we've sort of reinitiated these. This is actually only our second, and the idea really is for me to kind of share a little bit about what I'm up to, but also very interested in questions and comments, so that one of the big strategic beliefs that I have is that if I can't help the staff understand what we're trying to do, we'll never get it done. So sometimes you hear spoken of as line of sight, that connection between what we're trying to accomplish and how people see it affecting their daily lives and jobs. And so it's really intended to be a dialogue, and it probably was a little, made people a little nervous. Why was I called? This is not the principal's office. It's you would know what that means. But, sometimes I think people are afraid to come to the principal's office. And really, it's just an incredible time of change in our industry. But I heard it summed up the other day, and it was a little unnerving, but I thought it was, after thinking about it, I thought it was honest, and that is, as a society, when you look at us in totality, we can't afford the healthcare system we have. And so we're going through this rather interesting change process. And, I explain it in really three bodies of work. One is, we believe that everybody, as many people as possible, should have access to health care. So one of the things the Affordable Care Act does is expand access to care, because let's face it, the insurance card is what gets us access to care. And so that was piece one, is make it more accessible to folks. Two is, we've built a system of symptom and late-stage disease treatment. So, we have monitoring of cardiac patients because they've already had an episode and they're in the hospital. And there's this belief that maybe we ought to reorient where we spend and how we spend our money to reduce the incidences of disease. And so you see a real emphasis in the Affordable Care Act on prevention and earlier detection. This idea that if we can prevent a disease, that's the cheapest. If you can't prevent it, detect it early before it's a more complicated disease to treat. And then the third aspect of the bill and the change in public policy is we can't afford what we've got, so we've got to make it, it's too costly, we've got to make it cheaper. And it's not so much make it cheaper as it is slow the rate of increase in the growth of the cost. And this is the area that's the big push right. I mean, it's the pressure point, if you will. There's 10,000 people a day eligible for Medicare. New enrollees in Medicare, 10,000 a day. The average Medicare beneficiary uses about $400,000 worth of resources in their Medicare lifetime. So if you do the math on that, it's $40 million a day of new liability, if you will. And so we're trying to find ways to make it cheaper. So one of the things that gets talked about are end-of-life issues. You know, one of the phenomenons is that we use about half of that $400,000 in the last 6 months of our life, or in the last year of our life, I guess, is the statistic. And maybe sometimes appropriately, maybe sometimes if we'd have had a conversation with all of our kids before, maybe we wouldn't use all of those resources. That, I might add, is probably a very easy thing to talk about in the abstract, but put yourself and your mom or your dad in discussion, and it's a whole different discussion. It's not an easy topic to talk about. You'll remember that they tried to get counseling paid for in the bill, and that became the Sarah Palin death squads. We were going to actually pay hospitals to have people professionally trained to talk to families about end-of-life issues, and it became politicized, and we didn't get that part of the bill. So we're still relying on, you know, the nursing. A lot of it happens in critical care, which really should happen sooner than that, but a lot of it happens there. The clergy do a lot of it now, and we're trying to roll out a program called 5 Wishes that I like a lot, that Pastoral Care is trying to roll out, which is it's a structured way to have the conversation in a family, but it's really not about end-of-life issues. It's about, quote, 5 wishes. And it's a little more, it's a language it's easier to talk about, you know. So that's driving all kinds of interesting plays, and, you know, Medicare is trying, their theory is we'll shift this growing risk onto groups of providers, and they'll behave differently because now they've got the risk. So that's where your Medicare ACO or Accountable Care Organization comes from. But our response, response and our strategic direction is really pretty straightforward, and that is we need to reduce our risk. We need to reduce our areas of utilization that can be avoided. Readmissions is the best example of that that I can think of. And so we've set a number of objectives we'd like to achieve by 2017. One of them is the Maryland Performance Excellence Award. And really, what the Excellence Award is a measure of how consistently you do things the right way. So you figure out the best way to do something based on evidence or literature or whatever basis you use, and then standardize and replicate that process. And over time, that will prove to be the most efficient. It doesn't replace human judgment, but you tend to get the same outcome from the process if you do it the same way each time. And so a measure of how we're getting there will be these interim measures against this performance excellence criteria. And then, you know, quality matters. Outcomes matter now. They're reported, they're public. You can go to healthcare.gov and look at our scorecard, how we're doing. And frankly, we're average. And we've said we think it's in our interest to be in the top 10% in the country by 2017. We think it's a competitive advantage to be better than the people around you at what you do. And so a lot of this is that you'll hear talks about core measures, harm index. It's pretty, patient experience, that's a big push we have on right now on the patient side. It seems like it's complicated, but it's really not. I mean, if you really think about it, it's do the right thing the right way. It's make sure the patient's engaged and feels in as much control as possible, because that's where satisfaction comes from. And then finally, around the whole issue of do no harm. Something that we've said to each other for a long, long time, but patient falls are harm. Medication given at the wrong time is harm. Medication not given is harm. The wrong medication is harm. All of those things we're trying to get to zero defects on. And then NDNQI, nursing knows about this. This is really those measures of nursing performance and sort of a set of data around the nursing experience. So part of it is patient perception of nursing, but a lot of it is nursing's own perception of their experiences as nurses. And so some level of nurse satisfaction. Because we know that the single biggest predictor of patient satisfaction is direct caregiver satisfaction. So if if you got a unit where the nurses and staff feel good about the work they're doing, you tend to have higher patient satisfaction numbers on those units. It's a given. Nursing is working on Magnet, and in the confines of this room, I'll tell you, to me, that's the self-esteem goal. Because I think the nursing here is capable of performing in that top 4 or 5% in the country, which is what Magnet is an indication of. In our nursing practice, in the time I've been here, has broadened and broadened. We have a lot of advanced practice now. We're the school nurse program now, and that's all part of the collective nurse practice of this organization. And it's really pretty special, and people call all the time to talk about school nursing because they recognize as you move into this area of changing behaviors to improve health, starting at the school level makes a lot of sense. We have formed a Medicare ACO, so we are one of 6 in Maryland now. It'll get announced publicly right after the first of the year. The politicians like, we'll just go around the room. Tell me where you work too, please.
Okay, I'm Anita Palmer, and I'm an OR scheduler.
Ah,
Amanda Mungan, I'm Brett Kane's assistant, cardiovascular emergency services.
I'm Georgia Barton. I work for the lab in the nursing home program.
ah.
I'm Diane Reed, I'm a monitor tech for the hospital.
I am Vicky Petrie Dillon, and I am working for the school system.
Oh, yeah, school nurse.
I am a school nurse and also supervisor.
Good.
I'm Elaine Cochran. I used to work for Women's Health Center, but now I'm one of the centralized charge posters.
Oh, yeah.
So just getting that underway.
I'm Greg Winger, I work in information services.
Ah, one of the guys from the basement.
Yeah.
Good. Well, I have always done these gatherings, and when I got to Meritus, I got really busy really quickly, and I didn't initiate them right away, so we've sort of reinitiated these. This is actually only our second, and the idea really is for me to kind of share a little bit about what I'm up to, but also very interested in questions and comments, so that one of the big strategic beliefs that I have is that if I can't help the staff understand what we're trying to do, we'll never get it done. So sometimes you hear spoken of as line of sight, that connection between what we're trying to accomplish and how people see it affecting their daily lives and jobs. And so it's really intended to be a dialogue, and it probably was a little,